ladies and gentlemen. Our next speaker, she was introduced earlier, Dr. Niki Karavitaki, who's a clinical associate professor in endocrinology and honorary consultant endocrinologist at the Queen Elizabeth Hospital in Birmingham. She's going to talk today about Cushing syndrome management. Please welcome Dr. Karavitaki.
Thank you very much, Mr. Chairman. I haven't been able to come and see you face to face, but this talk is live and remote, so hopefully it will be as if I am there. And before I start, I would like to congratulate the organizers for such a beautiful meeting. It is wonderful. It is wonderful to see so much knowledge disseminated, so much practice shared. So many congratulations. So just give me a second to share my screen. There we are. And I hope we are okay and that my slides are shown. If they are not, please let me know. Okay. Right, ready to kick off, on a topic which is exciting, fascinating, challenging, headache, rewarding. Cushing's has everything, as we all know. And I've been asked to cover the management of Cushing's, but as a pituitary endocrinologist, I took the initiative to cover Cushing's disease. And these are my conflicts of interest on this topic. So what are we going to cover? We are going to cover management options, which include surgery, medical treatment, irradiation, bilateral adrenalectomy, a couple of words on Cushing's related morbidities and mortality, and finally some conclusions. So let's go straight to the point, because we don't have much time and we need to give robust and practical messages as evidence-based as possible. First line treatment for Cushing's disease is transsphenoidal surgery. There is no doubt of that, but we also know that 1/3 or up to half of the scans of patients with Cushing's disease remain negative. What does this mean? It means that we need to have an experienced surgeon who knows his job, who will explore the pituitary. He or she will explore it in a safe way, and at the same time, he or she will give us effective management, which will have an impact on the long-term prognosis of the patient. And once the surgery takes place, we have to define what is remission. And there are many criteria. If you look at various publications, you will see criteria which are all over the place. But the most robust one is blood cortisol below 55 nanomoles per liter, the units we use in the UK, or below 2 micrograms per DL. And there are various post-operative protocols on when we pick this up. In some centers, they offer hydrocortisone for a couple of days, then they stop it, and then they measure a morning cortisol. In some others, like ours, we do not offer hydrocortisone. We have a close monitoring of the patient every 6 hours with blood cortisol, close clinical review, and depending on the values of the cortisol we pick up, or whether the patient goes into adrenal crisis, hopefully very, very rare scenario, then we make a decision on remission. And we shouldn't forget that there are delayed remission cases which require monitoring for longer until we pick up the post-operative cortisol needed. Now, this value, the magic value, applies for most of the patients, but there are some exceptions, like patients with cyclical Cushing's, or patients with mild cortisol excess, or patients who have been treated medically preoperatively. And in these settings, in these scenarios, the HPA axis has not been, the normal HPA axis has not been suppressed by the cortisol excess or too much suppressed, and therefore we may pick up a higher cortisol simply because the normal corticotrophs have been working. In such a case, measurement of late night blood or salivary cortisol may be useful, because in cases of remission, we may pick up that the normal diurnal rhythm is back. And based on adult series and in good surgical hands, Remission has been reported in 73 to 76% of the microadenomas, and in macros, as expected, this is lower, around 43%. And there are many factors that have been reported to be associated with remission. I will just focus on three, which I consider as important. One is the tumor size and cavernous sinus invasion, particularly cavernous sinus invasion. We know that in CNOSP 3 or 4, for example, the surgeon should not touch this area, so we do expect that following surgery, the patient will still have Cushing's. Another factor is visible adenoma on imaging, and again, the surgeon's experience. And I grab this opportunity to put you this text here on screen, which involves considerations and recommendations for pituitary surgery. So this is from a paper we published, and it was a big group of experts in the Lancet Diabetes and Endocrinology in 2021. And is recommended that patients with Cushing's disease should undergo surgery in specialized pituitary tumor centers of excellence whenever possible, and surgery should be done by an experienced pituitary neurosurgeon with follow-up by a multidisciplinary team, including a pituitary endocrinologist. And not only this, but the outcomes of the pituitary surgery and the cost effectiveness should be reported and should be made publicly available. And one of the main reasons for that is because only if we audit our results and see which direction we are heading to, we will be able to improve and achieve better and better outcomes. Now, following successful surgery, obviously the patient remains on glucocorticoid replacement until the axis recovers. And here is where we need to educate our patient and his or her family members on the adrenal insufficiency, sick day rules, etc., etc. But what comes up in some patients, which makes things a little bit more difficult during the recovery phase, is the glucocorticoid withdrawal syndrome. We have patients who feel unwell, they have tiredness, muscle pains, joint pains, low mood, and this is usually glucocorticoid withdrawal syndrome, and we have to remember that the recovery may take 1 year or even longer. And some colleagues temporarily increase the glucocorticoid dose, but of course we need to make sure that we avoid iatrogenic Cushing's. From my side, I don't follow this practice unless it is we are dealing with an extreme case. I just warn and reassure my patient about that, that he or she will feel not well for a period of time, but for me, this is a good sign. And most of the patients accept it and have the patience to wait until they go back to normal. Now, the recovery of the axis usually is between 6 to 12 months, but we need to have robust management follow-up protocol for this. So the usual practice is to measure morning cortisol every 3 to 6 months after, of course, omitting hydrocortisone. The last dose of hydrocortisone should have been done on the morning of the previous day. And we would do a short synactin test if the cortisol is above 200 nanomoles per liter or 7.4 micrograms per DL. And once we have established that the axis has recovered, we need to assess for recurrence of the Cushing's, because this can be still an option. And in terms of numbers, recurrence has been reported in various series between 5 to 35%, depending on the length of follow-up and the definition of the Cushing's disease remission. My feeling is that the higher recurrence rates practically reflect cases in which the cortisol was not really undetectable post-operatively. There were different cutoffs, so in reality the patient was not in true remission. It is just that the cortisol excess became much lower, so they had some sort of Cushing's there in the background, and at some stage this flared up. Half of the recurrences are diagnosed within the first 5 years, but I can tell you that I've seen recurrence of Cushing's 20 years later, and I couldn't believe it, but it was true. So lifelong monitoring is required. And again, there are many factors which have been associated with recurrence. I think one of the most important ones is the early recovery of the HPA axis. So this should make us more alert that things may not go very well with the follow-up of this Cushing's disease of this particular patient. And how are we going to monitor the patient? How are we going to diagnose the recurrence? Obviously, as I mentioned before, we do this after the recovery, the HPA axis recovery, and regularly thereafter. So what tools are we going to use? And here is, I think, a very useful table which can give us some guidance. So late-night salivary cortisol has nice sensitivity and much better specificity. And it seems that in most patients, late-night salivary cortisol is abnormal before we see abnormalities in the dexamethasone suppression test or the urinary free cortisol. However, we have wide variability in results and we need serial tests. How about 24-hour urine-free cortisol? Not so good sensitivity, but good specificity. The problem is that it seems that this is the last test that shows abnormal results. In some centers, they have proposed the desmopressin test, which has, again, not so good sensitivity, but a quite optimal specificity. It is a labor-intensive testing, and some colleagues use it to predict the presence of corticotroph 2-1. And finally, 1 milligram dexamethasone suppression test, our well-known overnight dexamethasone suppression test. It can be used. It's likely to be abnormal before the 24-hour urine-free cortisol, but there is limited evidence specifically assessing its value for recurrence. So how are we going to monitor for recurrence? I think we need to take into account, first of all, what kind of tests were positive when our patient was diagnosed with Cushing's, and then we balance and we decide what to do. I personally I start with 1 milligram dexamethasone suppression test, mainly because an abnormal dexamethasone suppression test will make me take therapeutic decisions. Now, persistent or recurrent Cushing's disease, what are we going to do? Management options are repeat surgery, medical treatment, irradiate, or offer bilateral adrenalectomy. But irrespective of these management options, the approach should be individualized, and there should have been a multidisciplinary team discussion for this particular patient and decide what is best for him or her. And if we look at the repeat surgery, obviously we would consider this if there is no contraindication for surgery, if there is evidence of incomplete removal of the tumor or a pituitary lesion shown on imaging, and if we have negative imaging in case of persistent disease, we may consider to go back and ask ourselves, did this patient really have Cushing's disease? And this is where we will look at the previous pathology, if it was positive for a corticotroph adenoma, or in the IPSS results. Another point that determines eligibility for surgery for reoperation is the extracellular extension. A tumor which invades the cavernous sinus, we know that this operation will not be curative, will not lead in remission, so we take this into account. And remission rates, again, with various criteria for remission, various monitoring periods, have been reported in 37 to 88% of the cases, and there is higher risk, as probably expected, of endocrine and surgical complications, again highlighting the value of having an experienced surgeon to do this procedure. Now, medical treatment, yes, it is for persistent or recurrent disease, as we said, but also for patients who are not candidates or they refuse for whatever reason surgery. It can be used as bridge treatment after the radiotherapy. And the selection of the drug, and we will see a number of drugs that are now out, depends on many factors, like the mode and the rapidity of action, what is the side effects profile of this patient, how long do we think that this patient will be on treatment, what is the local availability of each medication, and in many healthcare systems, the cost plays a significant role. So let's have a journey now and look at various drugs that have been developed or are in use for Cushing's. And we will start with adrenal steroidogenesis inhibitors, and we go with the ketoconazole first. In various studies, it has been shown that in approximately 65% of the patients leads to normal urinary free cortisol initially, but up to 25% escape. We know the side effects, GI side effects, gynecomastia, liver dysfunction, and some key considerations here, and I've underlined the ones that I think we need to discuss. These agents decrease the testosterone, so in males we will have hypogonadism that needs to be followed up. There is a risk of serious hepatotoxicity, and there is a risk of acute TC prolongation. Another kid in the block is the osilodrostat, a very potent adrenal steroidogenesis inhibitor, which in a phase 3 randomized withdrawal study showed that we achieved normalization in 86% of the patients. However, this drug leads to the accumulation of androgenic and mineralocorticoid precursors with the consequences of hirsutism, hypertension, hypokalemia. We also may also have GI side effects, and something that is highlighted with this medication, because it is quite potent, is the risk of adrenal insufficiency. Again, QT polar prolongation could be there. The problem with cross-reactivity of 11-deoxycortisol in cortisol immunoassays is there. So how can we monitor this treatment? And we monitor for androgen excess manifestations in women. In the same family is methyramone, the same family with osilodrostat, and this has been in the market for a while. This is probably the favorite drug in the UK, and it leads in urinary free cortisol normalization in about 70% of the patients. This is from retrospective studies. Surprisingly, in a prospective study, in 47% at week 12. Similar side effects like osilodrostat, and similar key considerations when we look after patients who are on methyramone. Mitoten is a relatively toxic drug. We usually use it in adrenal cancer, but if someone considers to use it for Cushing's disease, and I've never done that, to be honest, we have to consider the side effects like GI disturbances, cognitive alterations, adrenal insufficiency, liver problems, and this drug has a slow onset of action, has high variable bioavailability and narrow therapeutic window, so we need to monitor for mitoten plasma concentrations. Again, there is cross-reactivity of 11-deoxycortisol in cortisol immunoassays, and the neurological toxicity. So it's not a drug that we would use in Cushing's disease, at least not in the UK. We move on to etomidate. This is the drug if we are in a hurry to manage the cortisol excess. It is given IV. Retrospective studies show in about 100% of patients serum cortisol control, but it can cause sedation or anesthesia. This is an anesthetic drug, as we know, adrenal insufficiency. And yes, it has rapid onset of action, but we may need intravenous hydrocortisone at high doses to avoid adrenal insufficiency. And another adrenal steroidogenesis inhibitor is the levoketoconazole, which is investigational, and in a phase 3 open label study, a normalization of urinary free cortisol was in 31% of the patients. We have GI side effects. We can have increased liver enzymes and adrenal insufficiency, and again, there is this risk of hepatotoxicity, liver toxicity is there. Probably it is lower than with ketoconazole, at least based on animal models, but we don't have head-to-head studies in human subjects. So that's about the adrenal steroidogenesis inhibitors. Let's go to somatostatin receptor ligands, and we have the pasireotide. And if we focus on the long-acting release, in a phase 3 study, there was a 40% urinary free cortisol normalization. but a side effect we are all aware for this third generation long-acting somatostatin analogs, second, I should say, generation, is problems with the glucose metabolism and, of course, the GI side effects. However, it can decrease tumor volume, and there is also a risk of QTc prolongation. And finally, we have the dopamine receptor agonist, cabergoline, which has been used as medical treatment in Cushing's. From retrospective studies, there is approximately 40% urinary free cortisol normalization, but roughly up to 40% escape. We know the side effects of dopamine agonists that were previously described nicely in the hyperprolactinemia session, and it can decrease the tumor volume. It has been reported, but we again need to keep in mind the side effects we need to follow. And finally, the glucocorticoid receptor blocker mifepriston, which in an open label phase 3 study showed significant improvement in hyperglycemia and in blood pressure. And we give this data because this is a receptor blocker, and therefore we don't have cortisol markers for efficacy. And there is a risk of hypokalemia and adrenal insufficiency. So these are the drugs we have in our armamentarium at the moment, and some considerations on when and how to use them. So if we want rapid normalization of cortisol, better to go with an adrenal steroidogenesis inhibitor like metyrapone or cilodrostar, or if there is an urgent scenario, etomidate. If there is mild disease with residual tumor, and we are hoping for potential tumor shrinkage, we could go for pasireotide and cabergoline, again keeping in mind the side effect profile. And in pregnant women, or those who are keen for pregnancy, we could consider cabergoline or metyrapone, but then knowing that these are not approved for use in pregnancy, though, so they would be off-label. But my advice in women of the reproductive age is, if they have active Cushing's, of course not, they should not try for pregnancy. Now, if we use the adrenal steroidogenesis inhibitor, so glucocorticoid receptor blockers, we need to do a pituitary MRI 6 to 12 months after starting this treatment and repeat every few years depending on the clinical case. And a question that may come up is, shall we offer preoperative medical treatment in Cushing's patients? There is no robust evidence in favor or against, but in patients with severe cortisol excess and potentially life-threatening complications like metabolic, psychiatric, infectious, cardiovascular, thromboembolic, in these patients, I think we need to consider the benefit for medical treatment preoperatively. And yes, there are no guidelines, but and sometimes we may treat ourselves rather than the patient by offering these agents. But I prefer to think that I have done something to make the whole environment of the patient safe before an operation. And again, the post-operative cortisol values in these cases, if the treatment has been for long, may not be reliable to confirm remission, as we also previously mentioned. How is the response assessed? This is a quite important question, and I don't think we have a robust answer. So we need clinical and biochemical endpoints, and in the glucocorticoid receptor blockers, just only clinical endpoints like weight, like blood pressure, like glucose metabolism. And if we offer medical treatment and the cortisol is persistently increased after 2 or 3 months on maximum tolerated doses, we have to consider changing treatment. And in the scenario that the cortisol has been reduced but not normalized, or if there is some sort of clinical improvement, we could consider combination therapies. But of course, we have to keep in mind the side effects profile of all these drugs and the potential overlapping toxicities. What has been used in the past is ketoconazole and metyrapone, and this can also offer the opportunity to use lower doses of both drugs, or various other combinations are reported in the literature, which could be considered. And again, we need to remember that these are not licensed. Lock and replace regime, so offer a high dose of a medical treatment plus hydrocortisone or other steroid. When are we going to consider this? We could consider it in severe disease, in cyclical Cushing's, which plays up and we don't know at which phase every day or every week or every month the patient is, and for poor candidates for surgery. So this is an option which can be useful in these settings. So now let's move on to radiotherapy. When are we going to use it? We are going to use it for persistent or recurrent disease if surgery is not an option, and also for aggressive tumor growth. And after the radiation, how do we follow up our patient? The usual policy is to measure 24-hour urine-free cortisol off medication, usually every 6 to 12 months, and also monitor if the patient develops manifestations of adrenal insufficiency whilst on medical treatment. And how effective is radiotherapy? And these are data from conventional or fractionated stereotactic radiotherapy. And we can see at the median follow-up of 3.5 years, remission of disease, again with variable criteria, 83%. And the Miniti paper, in which they showed that at 5 years, this was 78%. Tumor control really good, 97% at 8 years. And a clinical point we need to keep in mind when we consult the patients is that the average timing of remission is 24 months. So in my patients, to my patients, I give this interval, let's wait for 2 years and see what happens, and then we review our decisions. In terms of SRS, this is a summary of a published series with a median dose of 23 gray. We have very good tumor control again, remission rates quite good, most of them above 40 or even 50%. And again, the timing to remission is usually 14 to 26 months. The other option, the other tool, we have the bilateral adrenalectomy. When are we going to use it? Obviously, it is a life-preserving emergency treatment in severe Cushing's, which cannot be promptly controlled with drugs. Patients in such scenarios, which thankfully are very rare, are led to theater. We take the adrenals out with all these perioperative risks under these circumstances, and then gradually the patient transforms. We can also use this treatment not as an emergency therapy, but after failure of other management options. And the patient will have adrenal insufficiency as expected. My opinion is better to have adrenal insufficiency than active Cushing's. And the potential risk is the risk of Nelson syndrome, which is now mostly called corticotrophic tumor progression. And the prevalence is between 0 to 60% in series, again, depending on what criteria we are using for diagnosis and what is the length of the monitoring period. Predictive factors, a number of them have been checked, and there is no absolute agreement, but what seems to dominate is a visible corticotrophic tumor or high ACTH levels in the first years after the adrenalectomy. And again, we had published with a number of other expert colleagues recommendations on Nelson's. So how do we monitor the patients after bilateral adrenalectomy? We need imaging and actually thin slice thickness. So 1 to 2 millimeters after 3 months, and then every 12 months for the first years. After that, imaging is individualized. We can extend it to every 2 to 4 years, depending on ACTH and clinical parameters, and definitely clinical surveillance every month or earlier in high-risk patients. And this is a study we completed in the UK. We had 13 centers. It was led by Birmingham, 13 centers taking part. And we looked at what happened after the Nelson's tumor diagnosis. And as you can see from this curve, at 10 years, there was progression in 62% of the cases. And if we looked at management options, surgery and radiotherapy of the Nelsons provided better outcome rather than observation alone. And a very, very interesting finding that came from these 60-something, 67, whatever number of patients we had in the whole UK when centers took part, was that the Nelson's tumor prognosis, i.e. a Nelson's tumor Nelson's tumor being aggressive was predicted by complexity of previous treatments for the Cushing's before the Nelson's diagnosis. What does this mean? Patients who had Cushing's disease and required many treatments, when they had bilateral adrenalectomy, their Nelson's did not do well. My feeling is that this actually reflects the corticotroph adenoma aggressiveness from the very first outset, and we need to keep this in mind when we look after our patients in these scenarios. And before I finish, management of Cushing's does not mean only to get rid of the cortisol excess. It means that we have a thorough review and long-term monitoring of Cushing's disease-related morbidities. And there are many. I will just focus on a couple that I think we need to highlight. And we start with the hypercoagulability. There are a lot of opinions as to whether we should offer prophylactic anticoagulation. In our paper in the Lancet Diabetes Endocrinology, it was recommended that this should be considered for patients at risk for venous thromboembolic effects, like a history of embolism or abnormal coagulation testing, severe preoperative or postoperative hypercortisolism, use of estrogen or oral contraceptives, poor mobility, extended pre or post-operative hospital stay. In our center, we do offer low molecular weight heparin in practically all patients who have moderate to severe Cushing's based on clinical and biochemical picture. How long is this treatment going to be after surgery, after successful surgery? I don't think that anyone can give an answer to that. Another area, metabolic and cardiovascular. We do know how negative effects high cortisol excess has to these systems, but what is also known is that the excess weight, hypertension, diabetes mellitus, dyslipidemia may persist even after successful management of Cushing's. And this is another paper we had published again in the Diabetes Lancet Endocrinology, a collaborative study in which we looked at the mortality of patients with Cushing's disease who were in remission for a minimum of 10 years at study entry. So this was the nice group of patients that at the end did well, and we wanted to see what was their prognosis if they had stayed on remission for at least 10 years later. And look at the results. The SMR, the standardized mortality ratio overall, was increased, not massively increased, but increased. But the circulatory SMR was quite alarming, which means that in these patients, even after successful treatment, we need to have robust assessment of the cardiovascular risk factors and treat them accordingly. And also this study we had published in the Lancet Diabetes and Endocrinology 6 years ago, gave another very, very interesting and useful message in our clinical practice. The mortality of this group of patients was looked based on how many treatments these patients needed for their Cushing's. And in patients who had pituitary surgery as first and only treatment, the standardized mortality ratio was not high. So it was not alarming. In contrast, in patients who had 2 or 3 or even more treatments, this was high. What does this mean? It may mean that, yes, patients with aggressive tumors who needed more treatments, most likely they won't do well. But it also gives another message that the first packet of treatment we will offer to the patient defines his or her destiny to a major extent. So again, we need a good pituitary surgeon and a center of excellence, pituitary center of excellence, which will do their best to offer an appropriate packet of care for this patient. So in conclusion, I'm sure there is no doubt that Cushing's remains a challenging condition to manage. Surgery is the first-line treatment unless it is contraindicated. Experienced surgeon and care offered in pituitary centers of excellence is vital. We have many treatment options available for persistent or recurrent disease or in poor surgical candidates. I presented them to you, but I emphasize that we need an individualized approach with involvement of a multidisciplinary team. And appropriate management of the Cushing's related morbidities is mandatory for improving the long-term outcomes of these patients, their quality of life, and their survival. And I would like to finish with a statement, which is not mine. I read it somewhere in an editorial, and then other colleagues have repeated it. And it reminds me of how important it is to be modest when we deal with Cushing's, and to remember that it is a condition we will probably never be able to get a full insight. So the statement is that the endocrinologist who says he knows about Cushing's has not seen many Cushing's. So with this, I would like to thank you for your attention, and I would be delighted to take questions if this is allowed in this session. Many thanks again.
Thank you, Dr. Karavitaki, for an outstanding talk. Okay, there is one question.
That was an interesting talk. Thank you so much, Dr. Niki. Very nice review. Very happy that we have more armamentarium in terms of the medical management in those cases. It's extremely hard to find the right surgeon, and sometimes even to find the adenoma in cases with Cushing syndrome. So the list of medical drugs that we have is increasing, and recently the levoketoconazole have been approved as well. Several other drugs. How do you choose the drugs in terms of the choice among all of them? Is cost an issue in terms of side effect? Would you guide us like as an algorithm, which one you start first and in which cases?
Yeah, thank you. Thank you for this question. Yes, we have a lot of drugs in the management of Cushing's. My personal view is that personally, I'm not really sure if in the long term these drugs will lead to morbidity and mortality of that of the general population. But coming to your question, many factors will influence. In the UK, cost is important. And obviously experience that we have with medications. My first choice is methyramone. It is methyramone because we know how, more or less, how to titrate the dose. We know that it has a quick onset of action, and it is effective in many cases. If this does not work, or if the patient has side effects, I would combine it with ketoconazole. We don't have other drugs. Oscillodrostat is coming in the UK. We don't, cabergoline may be used, but it's for mild cases, so I wouldn't go for that in mild Cushing's, sorry, in non-mild Cushing's. And pasireotide has this risk of diabetes development. So my algorithm is methyramone or ketoconazole. I prefer methyramone, then combination of these two, and then management is individualized.
Okay, any more questions?
Difficult answer.
Any more question?
I just want to ask the professor the prevalence of Cushing disease in the United Kingdom, and do you have as many of junior doctor, senior doctor mixed between with metabolic syndrome, metabolic syndrome and Cushing? I mean, the resemblance is there externally. How could you approach this problem?
In which way? In terms of diagnosing Cushing's? Or in dealing with a metabolic syndrome that relates with Cushing's?
Metabolic syndrome, you will have an increased cortisol, and metabolic syndrome externally they look the same, obesity and problems, and then you need to spot this, so.
Absolutely, absolutely. In such a case, obviously, we have to look at some more specific signs that would point towards Cushing's. So, for example, young onset hypertension, or proximal muscle weakness, or purple striae, or young onset osteoporosis. So there are some signals there that I would like to pick up for each particular patient, and then decide if I will proceed with investigations and what kind of investigations. So I wouldn't check anyone with metabolic syndrome. This would be a nightmare. And of course, we have to consider the risk of false positive results and what this could mean for the patient and for the healthcare system, as this would initiate investigations which would take long until we clear the patient. So specific signs and symptoms I would look at, not just metabolic or obesity.
Thank you, Dr. Karavitaki, for being with us for the second time. We really appreciate it. And now we are going to move to the next